Uh, Good evening, everybody, and good afternoon for anybody from Europe and the rest of the world. Thank you very much for joining us today. My name is Dr. Khalid Abu Haliqa. I'm the Vice President of the Emirates Society of Ophthalmology. I am going to moderate today our second session in the Thyroid Eye Disease Educational Series. All you need to know about TED, basically. And today we are very glad to have prominent speakers with us. First speaker is going to be Dr. Mario Salvi. Dr. Mario is a consultant endocrinologist, founder and head of Graves Orbitopathy Center, which is in Milan, Italy. Dr. Salvi is a Yogogo guideline leader and co-author on the latest ETA consensus on thyroid eye disease. Dr. Salvi carries out research in the field of autoimmune thyroid diseases at the University of Milan. He also taught endocrinology at the University of Parma and McGill University of Montreal in Canada. He's extensively involved in clinical trials on thyroid eye disease with more than 240 publications on peer-reviewed international journals. Also with us today is Dr. Habibullah Timadi, who will do the second talk about case-oriented session. Dr. Habib is a consultant oculoplastic and orbital surgeon at Sheikh Shakhbout Medical City in Abu Dhabi, United Arab Emirates. He has done his postgraduate training in oculoplastic and orbital surgery at Nottingham University Hospital and London Western Eye Hospital in the UK. Dr. Timadi, main subject of interest is medical and surgical management of oculoplastic and orbital diseases of the eye. He has special interest, obviously, in thyroid eye disease, also orbital immunological disease and orbital tumor. So we are happy now for the first talk to hear from Dr. Mario Salvi with his talk. Please, Dr. Salvi, you can go ahead and share your screen.
Do you see my screen?
We're waiting for it to upload, I believe. Can we have Dr. Salvi's screen on? Can we put it on?
Dr. Mario, you can share your screen.
Okay, so he has to share it from his side. Okay.
I did it before.
I think you have to do it again. Let's.
Okay. So to do it again, hold on a sec, because I thought I did it. Sorry, but I can't. Okay, let me see if I can do it like that.
Okay, we just go on. Yes, perfect. On full. Can we go full slide? Yes, and now from the beginning, Dr. Salvi.
Okay, let me just. Okay.
Yes, perfect.
Okay, I thank Dr. Khaled for the presentation and the organizer for the invitation. I will try to go through what the main lines are of the consensus document that we reached we published about the management of thyroid eye disease. Just by introducing it, I think everybody knows that this is a peculiar disease. It's a diphasic course. There is an active phase of disease, which is the phase in which disease progresses, and it characterized by mostly by inflammation. And then this curve, the Randall curve, reaches a plateau, and the disease even spontaneously stabilizes and somehow improves. And the relationship between the duration of the activity of the disease and the severity is really not quite clear. What we know, though, that we're trying to, in the assessment of these phases of disease, we have some tools that have been used and have been validated. The clinical activity score is a score of inflammation that substantially allows us to try to grade the degree of activity, and it's composed by 7 items at first examination, which are mostly inflammatory signs, and 2 signs are related to a symptom of the patient, the pain in the orbit, and it can be extended to a 10-point scoring scheme at a second examination, in which we really assess progression of proptosis, of the motility disturbances, and of visual, if there is any visual impairment. The severity of disease is somehow a little more complicated in terms of there is certainly very easily defined the mild form of disease, in which the signs of disease are not impacting much on daily life of the patient. Then we do have the very severe disease, which is actually usually due to optic compression, the compression of the optic nerve or corneal breakdown. And then there is a range of disease between the mild and the severe, which we called, and this was a consensus document that UGOGO published a few years ago, in which there are several degrees of disease, which is very heterogeneous, and usually it's characterized by impact on the daily life with an important degree of proptosis, of diplopia, and lid retraction based on the various evolvement in the progression of the disease. The characteristic of this disease, as I was saying, is very heterogeneous because not all patients present the same way. This disease is as if there are some different phenotypes of disease. The most important, the most pathological signs that relate to the manifestation as the lid retraction, proptosis, which results from the forward push of the globus, chemosis and periorbital edema, so inflammatory signs, and restriction in eye duction, which sometimes are not even accompanied by inflammation. So the disease, when it's presented, it presents in different ways. And one of the main topic of discussion among the task force when we worked on those guidelines was really to approach the disease based on the target of treatment. And I will go through that to explain in detail what we did. Mild TED is usually a disease that doesn't impact much on daily life, and data that have been produced in a control study by UGOGO suggest that a short course of selenium may improve the signs, but the disease the patient can even just be watched and monitored. In some cases, if there's some inflammatory signs, it is acceptable to give some oral steroids. In general, when the disease is inactive, there are usually corrective procedures that mostly related to lid correction of lid malpositions. So the conclusion of the guidelines of the consensus document was that usually local measure and lifestyle intervention with lubricants and masks can be important for this disease, when the disease is mild. There can be suggested a single course of selenium for 6 months, because studies have shown some degree of improvement on that. But what is important is to monitor also the psychosocial impact of this form of disease. When we go to manage to moderate severe disease, here by comparison, I show what the UGOGO guidelines suggested, the latest version of the UGOGO guidelines suggested. And the approach of the UGOGO was to have a first-line treatment, which is usually related to steroid therapy, and a second-line treatment when the patient is not responding to steroid. The difference with the ATA consensus documents was, instead of approaching a treatment based on the goal that and the different characteristic, the heterogeneity of disease presentation. So if we want to target this disease activity, so we want just inactivate disease, we can use different kind of treatment. If the focus is the reduction of proptosis, we propose something different. And if the target of treatment, if the motility is diplopia, we may propose different treatment. And based on the evidence-based data that are produced, although very few, we try to construct an algorithm in order to give some direction about treatment. And when we talk about steroids, this is a seminal study that was done at the multi-center study conducted in Ugogo centers a few years ago in 2012. This was published, in which a dosing of steroid was compared vis-a-vis the outcome in terms of efficacy. And then you see here, 3 different doses of steroids were proposed, and the differences that you can observe at 6 weeks and 12 weeks, inactivation was obtained in more than 80% of patients with both the intermediate doses and the high doses. When we go to the overall ophthalmic improvement, just the high doses seem to reach significant efficacies at about 50%. Obviously, when we compare doses, we also have to consider the impact of high doses on side effects. Therefore, the conclusion was that intermediate doses regimen of steroids is to be used in most cases, whereas high dose regimen should be reserved also to the more severe patients. What is the problem with steroids? This is the Randall curve. Some patients do not respond at all to that, or some patients seem to have response, but then relapse after the course of treatment. And what is interesting is that we also know very well that the earlier we treat, the better we have in terms of efficacy and effectiveness at the end of treatment. So this graph that I prepared is really showing a little bit what the situation is. We know that if we want to have effectiveness of treatment, we have to treat patients during the active phase. The point is that we do not know what the duration of the active phase is in this, suppose in this curve, the Randall curve. And as you see here with the dashed lines, there can be a patient with less active disease but longer activity period, or vice versa, high with a shorter activity period. So if we by any chance stop treatment, where you see this red arrow, with at some point, let's consider this could be the 12 weeks of course of steroids. We stop at this point, the activity course, the phase of activity in this patient is not finished. So I would expect that after steroids, there is a relapse of disease. So inflammation comes back. And this can be the explanation of why in some patients, and with all the treatment that have been used so far, we do observe a relapse of the disease after the course of immunosuppression. So this workflow proposed is, and with the study that was conducted with steroids, is that if we have a response, we can proceed with 6 weeks of 500 followed by 6 weeks of 250 milligrams for 12 weeks complete. But we stop at 6 weeks because if GO deteriorates, if TED deteriorates after 6 weeks, that means this patient is not responding to steroids. If the response is not observed, we may have a situation in which don't develop, and we will deal with that later on, or else we have to think about considering combination therapy or moving on to the so-called second-level immunosuppressants. So the conclusion of the task force that certainly steroid therapy is the preferred treatment for active moderate severe disease when the prominent feature is activity, is inflammation. The dose is usually an intermediate dose of 4.5 that can be increased to higher doses if we want to impact more on motility. Poor response at 6 weeks should make us consider alternative treatment to it. And we have to be sure that for safety reasons, we cannot go beyond a total cumulative dose of 8 grams in the patients in the whole course. So what are the alternatives to steroids? Second line, and this is the list of all the drugs that there are studies or have been studies, and but it's very limited. And these graphs that I more in detail underscore the few data that we have from evidence-based studies, and they are really related to glucocorticoids, rituximab, tocilizumab, and teprotumumab. And I would focus mostly on the data produced in randomized clinical trial. Rituximab was studied by our group some 15 years ago. And when we performed the study, we compared rituximab to intravenous steroid, and we observed a very significant response. All patients treated with rituximab inactivates versus 70% of patients treated with steroids. On the other hand, the American colleagues at the Mayo Clinic performed a similar study in which they compared rituximab to placebo, and they were not able to see significant results. And the reason why this was the case, this contradictory response, was because of patient selection. And when we did study in detail this, the two studies were in a post-hoc analysis. Mario Stan and myself, we did analyze the data. We observed that the main difference between the Italian study was the disease duration, being 4.5 months in the Italian patients and up to 30 months or more in the American patients, even considering that the Italian study had more smokers than the US patients. So the evidence from the randomized trial is limited and divergent, but suggests that rituximab can be used for inactivation of TED as long as the disease is of low duration, so before 1 year. And it certainly shows very, very, very nicely that in that case, when it's effective, then the percentage of relapses is very, very low. So the conclusion also is that this therapy is accepted, especially in patients with prominent signs of inflammation. I mentioned teprotumumab, and teprotumumab is currently the only drug that is approved for treatment of thyroid eye disease, although this approval is certainly, this was approved by FDA in 2020 and recently has been approved in Japan. And teprotumumab is an anti-IGF-1 receptor antibody that interacts with this specific crosstalk with the TSH receptor antibody, especially on the surface of fibroblasts that are stimulated, early stimulated to become adipocytes and still stimulate adipogenesis in this disease. And these two studies were conducted, two randomized control studies, overall 84 patients treated with teprotumumab versus a similar number of patients treated with placebo. And the result was striking because for the first time, a drug showed a significant improvement, as you see here, a significant decrease of proptosis in this patient at 24 weeks. Which has an average of 3.3 millimeters, but in some patients was greater than that. And together with the reduction of proptosis, certainly there was also a significant reduction of inflammation, although not as marked, and with an overall response of 78%. You see 83% of patients did respond with proptosis. And was shown also in some patients that there was a specific effect on the size of the eye muscle, as is shown in this slide, after treatment, the treatment with the teprotumumab. This slide summarizes a little bit the studies, the phase 2, the phase 3 study, and also an open label study that was allowed to treat patients, non-responder or relapsing patient with teprotumumab after 24 weeks. And what is confirmed is very interesting, is that both were very significant, with the point though that both these studies showed that about 30% of patients have relapse, proptosis relapse at the end after the course of treatment. So teprotumumab, the task force concluded is preferred therapy when available in patients with active moderate severe thyroid eye disease with significant proptosis and diplopia, because the effect of diplopia was also significant. Then some reports have come out recently about reporting especially a very significant relapse rate in this patient. This is not a control study, but these reports have been more and more underscored by investigators, especially in the USA, where this drug is used. This study was really looking at the long-term outcome of patient treated with Tepro in the two randomized trials. And as you see, the follow-up was up to 72 weeks. As you see, in fact, there is some degree of relapse of proptosis, whereas the patients seem to be inactive. 90% of patients seem to remain inactive, and everything related to composite score as well. With proptosis at 72 weeks, some 30% of patients did show relapse. Interestingly, Tepro was also studied for the first time, and this is the first drug that is used in chronic patients. And a nice study was conducted last year, and these are the results, in which patients had long duration disease, up to 24 months of disease, actually from 12 to 5 years disease. And as you see here, it's interesting because even in this patient, there was a reduction of proptosis, although it was not as marked as it was in the active patients. Unfortunately, in this study, the diplopia, the results and improvement of diplopia could not be reliably assessed because most of these patients did not have significant diplopia. So I think this is something that we should further look into that, because the effect of Tepro on diplopia is really impressive, and I think it is very important in terms of that as a major disability for the patient. The next drug that was studied in randomized trial is tocilizumab. Tocilizumab is a monoclonal antibody that interacts with a soluble receptor of IL-6. And this IL-6 is a cytokine that is highly produced in the active phase of disease. And one randomized study conducted by some Spanish ophthalmologist, colleague ophthalmologist, and was published 5 or 6 years ago, showed nicely a significant inactivation of disease of patients treated with tocilizumab versus placebo as week 16, with a significant inactivation, the decrease of 2 points of the clinical activity score, and significant inactivation compared to placebo. This difference was not significant at 40 weeks. Tocilizumab in this study was administered with one IV infusion every month. Now it's also available, the subcutaneous administration. These data are, though, very interesting. One thing that has to be assessed very clearly is the response in terms of proptosis, the percentage of proptosis responders and the degree of proptosis, because in early studies, they were reported to be very, very significant. So the conclusion of the task force that tocilizumab is acceptable for inactivation, especially in patients resistant to steroids, because this was the population studied in this clinical trial. And both together with rituximab, it can be considered for inactivation in patients as second-line treatment after resistance to steroid. Whereas teprotumumab has only been studied in patients naive of treatment. We have just concluded the recruitment of a multi-center trial conducted in Italy on tocilizumab versus IV steroids. The last patient last visit was 3 weeks ago, and I'm going to be, I'm the PI of the study, and we are going to this week lock the database, and we hopefully will have soon results about the data when, in this case, of tocilizumab compared to the standard IV steroid IV treatment. So this to summarize a little bit the data that are available in the literature on randomized controlled trial, which we summarized in the consensus document of the ETA and ATA, we prepared this heat map. And this heat map, the more color you have, the more effective it is. And as you see here at the top, we actually consider the target of treatment, which is inactivation of disease, proptosis, diplopia, and we also looked at the disease relapse. And I want to point out the data that we collected from patients treated with placebo in the randomized control study. And you see that nevertheless, between 22 and 60% of patients do inactivate even without treatment. So when we compare, and we have to consider that, we see that the range of inactivation goes from 80% around with steroids. Rituximab has shown in one study to inactivate all of patients, in another study of long duration not to be effective in that. Tepro certainly was significant in inactivating in about 60% of patients, and tocilizumab 93% of patients. But when we go to proptosis and diplopia, the only drug that really showed significant impact on these features was teprotumumab. Although this was accompanied by about 30% relapse rate, which is not actually observed with rituximab and with other immunosuppressants. I showed you before a list of other drugs that are being studied and are under study. This study, for example, involves the study of batoclimab, which is an inhibitor. Actually, it's an inhibitor of this FcRn antigen, which clears the immunoglobulin for circulation. And as you see, with batoclimab, you have a sharp decrease of immunoglobulin. This is not specifically of immunoglobulin to a TSH receptor antibody, but all immunoglobulins. And this study should be concluded soon, and data should be available shortly. Another drug that is being studied is another IL-6 inhibitor. This is a drug that's called satralizumab that has been used in optic neuritis with significant effect. And the recruitment is going to be closed soon. And it's a multicenter US and European study. An oral IGF-1 receptor inhibitor, lincitinib, has also been studied. The study is about to be concluding the recruitment now. And what is interesting is in an animal model, it really did show very nicely also a reduction of the immune pattern of the disease in the animal model for TED. And also, this is the data published of a phase 1 study of K170, which is a pure significant specific inhibitor of the TSH receptor. It's an antibody, and a phase 2 study is being planned and is going to be underway in the next year. Site-threatening TED, very shortly, data that are available here has led the task force to conclude that when we have compressive nocturnal neuropathy, certainly the first action to take is to give high-dose steroids, which can be accompanied by radiotherapy. And the gold standard, though, is orbital decompression. But we have seen that pre-treating patients with steroid has given certain advantages. This was a very early study by the Dutch group that showed that when you treat patients with high-dose steroids, you prevent the need for acute orbital decompression is in about 40% of patients. And we did confirm in a study about 10 years ago the same data. So by pre-treating patients with steroids, we may avoid optical decompression in some of these patients. And interestingly, in a study we just published last year, we observed that even with previous medical therapy, we do have significant results. So the outcome of surgery is better, with a better improvement of the visual acuity, and also obviously better improvement of proptosis. So patients with DON require urgent treatment with steroid therapy and close monitoring of response about 2 weeks after this course of steroids. And if there is no response, the compression surgery is certainly what is needed. And this slide, acknowledges the group, my group, and people working. We work in a joint clinic, and we have close collaboration with our ophthalmologist, the ENT surgeon who in our institution perform optical decompression surgery. And we have biologists and study coordinators for clinical studies because we're also involved in some basic studies in this disease. Thank you.
Thank you very much, Dr. Mario Salvi, for your very informative talk. We appreciate it. I just want to let the participant know to put in their questions in the Q&A section of the Zoom meeting, and we will answer. Our speakers will answer them at the end. I am happy now to introduce my good friend and colleague, Dr. Habibullah Ahtimadi. As I mentioned earlier, consultant oculoplastic and orbital surgeon, who will be talking to us about specific clinical cases. Dr. Habib, you can share your screen with us. Dr. Habib.
Can you hear me now?
Yeah, you can share your screen and we can start your talk.
Start my video, it says. What should I say? Start my video or what? No.
No, you can share your screen so you can start your we'll be happy to listen. Thank you.
See this one. Start my video as well.
No, yeah, you are on the screen on the
Can you
case.
see me now? Can you see me?
Yeah, we can see you. You can go on full screen so that we can.
Okay.
Yeah, that's perfect.
Okay. So thank you very much. That was a beautiful lecture, Prof. Really, really nice. And I was making some notes, and I would ask you a couple of questions. So for Izo, thank you for the opportunity. Khalid, yourself. So I will go through a couple of cases. I will be very short. There will be a couple of questions to see how other people would manage. And let's take the first case. So this is a case who came a recent onset thyroid eye disease. He is hyperthyroid. He has hyperthyroidism. And so he comes with this picture of slight pain, a little bit of, redness, more proptosis in the right eye. So what would you do in this case? It's only a very short history, so 4 or 5 months. Would you observe and give selenium, systemic steroid, IV steroids, tocilizumab, or teprotumumab?
Okay. For the participant, please click on your choice on the screen, and the results will appear shortly.
Excellent. Yeah, I would agree with you. It's either observe and selenium. That's excellent result. Okay, so next. Okay, so this is observe and selenium. This is him after a couple of months. Really, he did beautifully well. So this is, as Prof was saying, selenium is effective actually in mild cases, in many cases. Case 2, she comes with bilateral proptosis, which doesn't show that much here, but she has, I don't remember exactly, but she has quite severe that she is very dry. She doesn't feel well. She says, what is the option? Okay. But she's quiet. The CAS is nearly 0, really. What would you do here? There is no pain or anything. Would you observe steroids, decompression, or rituximab? Good. I think I personally would do a decompression because the case is quite stable for a while, at least 6 months, and we did a decompression. Just 1 second. We did a decompression. She's very happy. She went up, lower. I didn't do lower lid. What I do sometimes, I do lower lid retractor disinsertion, and the eyelid goes up by 1 or 2 millimeters, which is a good result. She's very happy. The dryness, she even doesn't use the lubrication. Next case. This is in 2014 with quite active thyroid eye disease, pain, double vision, proptosis, edema. She's very unhappy. She wants to get married and everything, but there is no optic nerve compression, a bit of exposure. What would you do? Okay, excellent. Yeah, I agree actually with both of the either systemic steroid and systemic steroid. Waiting at least 6 months, if everything is stable, thyroid function, everything is stable, you can do a decompression. So this is following orbital decompression. This is following the IV steroids in 2015. Yearly, still she is active, but then slowly she improved her function. She was like this, for a year nearly, and this is after her decompression. So I agree with you. She had so it took 3 years for this lady to get settled. I saw her a couple of days ago. She came with her parents for cataract surgery. This patient is quite very, very complex. Okay, he came in 2017 with left. This is exposure. The thyroid is a stable thyroid eye disease. There is a bit of edema, but because of his family and social, we did a decompression in the left eye. And we did a lot of fat decompression. He improved a lot. I don't have his post-op because he didn't come, or I didn't find his pictures. So he was nearly similar, okay, right and left. Left eye there was a residual proptosis, but he was okay. He was very happy. Then he went into this in 2022. I think it had to do something with the COVID, okay? So the left eye went out of proportion, really. Okay, so what would you do? Good. Okay. All options are viable. You can do repeat orbital decompression, which I couldn't do because we had done lateral orbital decompression nearly full, and I don't think I can get with medial orbital decompression more than 2 millimeters in my hand. IV steroids followed by orbital decompression, an option, but I cannot do in this case. I'm not that skilled to maximize the decompression. So I told them that, look, let's try the teprotumumab, and this is him after 3 doses. He wants decompression more. I said, wait 6 months, 8 months. He has been happy, so we may consider now we can do a bit of medial decompression, a bit of top-up lateral decompression to make him a bit better. But taking his story of recurrences, I would say I would be very conservative in redoing surgeries in him. So he's very happy. So this is the case. He is 18 or 19 years of age, actually 19 years of age. He came with severe bilateral proptosis and right eye corneal ulcer. So what would you do? Well, excellent. Yeah. I referred the patient to cornea team, and they treated him beautifully well. We have an excellent excellent cornea team. So they treated his cornea, and this is him after the cornea. Obviously, he got a bit worse, actually, his thyroid eye disease. So not because of the corneal ulcer, but he was progressively. So this is about 3-4 months later, actually, because he had to travel abroad and come back. And while he was abroad, actually, he got this corneal ulcer. And this is him. We didn't do IV steroids. We didn't do decompression. I wouldn't do a decompression on an 18 or 19 years of age. I haven't done any actually at this age. I'm very, very conservative in these cases. So he beautifully improved to 24 millimeters, nearly 24 in both eyes with you can see there is a bit of a scar here in the cornea, but his vision is nearly 6/9. He's happy. Now, this lady came to me saying that, look, this is how I was when I young. She was very upset with this. So she was thyroid eye disease, recent onset. She went to a couple of other eye doctors in UAE. They offered her upper lid lowering, upper lid blepharoplasty, lower lid blepharoplasty, and she had approval from and she was active. She has double vision. She has pain behind the eye. Her vision is okay. What would you do? So I'm glad that nobody said upper lid lowering and blef. This was offered to her in a couple of hospitals, and the selenium and oral, it's an option, but this is not in our practice. And IV steroids could be an excellent option. Actually, we did the following. We gave her the option of the teprotumumab, and this is her after. Believe me, this is only 4 or 5 doses of the teprotumumab. Okay. Now I'll show you something. I want to tell you something about this case. She did beautifully well. She completed the course. I'm waiting for her to see her. I generally see them in a couple of months time after the last dose of teprotumumab. And so this is how she came in. She said, "Can you take me back to this?" Of course, this is years ago. I mean, she's much, much younger. And this is after teprotumumab. I think this is very much acceptable. She would need a bit of upper lid lowering. At the moment, she's not interested, but I would recommend her to do a bit of upper lid lowering and maybe a bit of lower lid blepharoplasty. She would do beautifully well. Now, this is a very interesting case. She came with a visual, I think his visual acuity was less than 660, nearly 1 year history of treatment and everything, counting finger, and she had already decompression medial and lateral elsewhere. And this is after the decompression, after nearly how many grams of IV steroids and everything. So when she came, the vision was nearly counting fingers, and you can see the CT scan, the muscle. You can see beautiful decompression, which she had done actually. Look at that. Look at that. I cannot do this kind of beautiful decompression. It's very nice. It is done. And but the muscles, how can you cannot you can go and chop these muscles off. Still, he's going to. I think you can go and cut them into half, like how you eat the sausages. So this is his visual fields. He had optic nerve compression bilateral. So what would you do? Well, interesting. I didn't put teprotumumab here. I didn't put anything else here. Okay, so deliberately. So orbital radiation is a good option. I have no experience because we don't do orbital radiation in UAE. Actually, our institute don't do. My colleagues. I think in Tawam they do, but I had only one patient in the past 15 years with orbital radiation. So I don't have experience with rituximab. So what we did was that we treated him with tocilizumab, okay, 4 doses, and this is after tocilizumab completion 6 months later, 4 months, 4 doses, 8 milligram per kilogram. His vision is now 6.9, both eyes. He has a bit of pale optic disc, but he's over happy. And this is how he was when he came in. And this is him when our colleague, Dr. Ashwaq, she did our pediatric ophthalmologist consultant, she did the squint surgery. And then I did a bit of upper lid bleph and the debulking of the roof and so on. He's very happy, over the moon, alhamdulillah. So this is him and this is him. So I don't know twice. Now this case is interesting. Look at both eyes, okay? Look at both eyes. Left eye is active. He has a bit of pain. He's very unhappy about the swelling of the left lower lid. Chemosis, what would you do? Of course, thyroid eye disease. All of these are proven thyroid eye disease. Excellent. I'm very happy for your answer. I think your options are excellent. So there is no right or wrong here. You could easily wait 6 months. You can give him selenium. You can wait and see. But often these cases, when it is more than 6 months, the natural history, he's getting a bit worse actually, till we could treat him. So this is him before the treatment, and this is him after the treatment with 8 doses of the teprotumumab. Now I want you to look at one thing, okay? Look at the right eye. Obviously, I thought there is no thyroid eye disease in the right eye, but look at the effect of the teprotumumab. He had right eye proptosis and inflammation and redness. And look at the massive decrease in the edema and swelling of the left lower lid. I have offered him left lower lid decompression, but maybe in a couple of months' time, at least 6 months after the last dose of the teprotumumab, he is to decide and come back to me. So I want to show you 2 things, okay, a couple of things. I'm done, Khalid. Just I will show you a couple of points. Now, this is a case which over 24 weeks, he came back to the picture which he showed me. He said, "Oh, Habib, I'm happy now with my look." And this lady, she's very happy with her look, but it took nearly 3 years, okay, to do IV infusion, eye steroids, followed by decompression, followed by upper and lower lid lowering, followed by, 3-4 surgeries, and all hospitalizations and so on. So this time, I think it matters for the patients, for the workplace, for the productivity, for the country, and everything, and practically, you're not exposing the patients to any GA, anesthesia, bleeding, and so on. Now, this is another case, this case which is at the top, we treated 3-4 years ago, and this patient, if neglected, could have gone in this path. Okay, look at his cornea and look at his eye movements. Because this is delayed treatment. Prof was saying that the earlier you treat, the better results you get. This is a delayed treatment. Eye muscles, optic nerve compression, corneal exposure, and everything. And this is treatment after 3 months. And this is the treatment after 2 or 3 years. Still, he needs more surgeries. You see the difference, By the way, this vision in here is, you don't believe me, but it's 6.9. The vision is 6.9 with this cornea, and I don't know what cornea people are going to do with it, but he needs a couple of more surgeries. So I'm very thankful, happy to discuss. for the opportunity. Again, happy to discuss.
Thank you very much, Dr. Habib, for your excellent talk. Dear participant, please, if you have any questions, please put them in the Q&A in the Zoom menu, so we can answer them if you have any question for our speakers. I believe, Dr. Habib, you have some questions for Professor Salvi. We can.
I have a couple of questions. Prof, that was an amazing talk. And so I didn't understand regarding the rituximab. In your study, I have seen that study, but can you, while you are there, while you were involved, so your results, they were 100% improvement in CAS more than 2.
Yes.
I see. Okay. And do you use it?
All patients inactivated, whether they decreased the CAS of 2 or they, at the end, they had a CAS less than 3.
And you recommend, if you want to use it within the first year of this, the start of the disease?
Yes, actually, we are using it consistently. And what we're doing is that certainly we do use it when the disease is very active in the initial phase, sometimes even as first line treatment. You know that we don't have TEPRO in Europe, so we do have to work on off-label drugs anyways. What we are doing now, we're doing some studies related to the, this is an organ-specific disease. So what we want to do is we want to understand what happens in the orbit. So we are studying, because we've done some cytofluorimetry study of immune cells in the orbit, patients decompressed with dawn and various degrees of activity. And we find that the orbit is full of B cells. And there is a difference between what you find, the pattern you find in the circulation and what you find in the orbit. But also we do study the thyroid compartment, and we do also by fine needle biopsy. And we also do fine needle biopsy of the lymph nodes of the neck, which resemble very much what happens in the orbit. And what we do is that based on what we have, I mean, we do cytofluorimetry in 48 hours. We see what the pattern is, and we decide which immunosuppressant to give. And what, as it turns out, some patients do have prevailing B cells infiltration in the orbit and in the lymph node, and they respond very nicely to rituximab. But what we have seen also that when you give rituximab, you measure B cells in the circulation. After half an hour, there are no more B cells. Okay, so it's after half an hour, you don't see B cells. But that's not the same thing that happens in the target organs. Because by monitoring, for example, the biopsy of the lymph nodes, we see that it takes at least 2 cycles of rituximab to deplete B cells from the lymph node. And that relates very well, and actually we have data that are about to be published, this, with the inactivation of disease. So just to underscore, the disease is very heterogeneous. I don't think there's the pattern of immune cells is the same in any patients.
Yeah.
And so if we have a way to somehow find some specific markers, then we really do need, we can do some specific targeted therapy. And in the case of rituximab, as I say, I think the discrepancies that were found between our studies and the American studies were certainly related to the disease duration. I mean, it was much, much more late disease. But on the other hand, I think you can even super select the patient you treat by, simply looking at their immune competent cells, because they are not the same. And I think that the different feature of disease are related to what the different immunology is in this patient. Because some patients, have very high TSH receptor antibodies. Some patients do not have high levels of TSH receptor antibodies. IGF-1 receptor antibodies have not been found consistently. So there is something that we still don't know about the disease.
Thank you very much, Prof.
Thank you.
There is few questions from our audience today. The question is, do you use TEPRO for vision-threatening thyroid eye disease, even if it is not approved for that? I mean, it's not approved, obviously, by the FDA for vision-threatening thyroid eye disease. It's not recommending as per the ETA. But is there can we use it? What do you think?
Is it to me or to Prof?
Both of you, what do you think?
We have extensively used tocilizumab for optic nerve compression in thyroid eye disease, and we published, I think, the first paper in this report a couple of months ago, the effectiveness. And I have one patient only, which we have treated with teprotumumab, and the vision came up beautifully well.
So you were able to access the medication and give the medication within a short period of time for this vision-threatening thyroid eye disease?
That's a very good question, and I'm interested to see what Prof says. You see, I don't think anymore, okay, if you see our series, I don't think anymore, I mean, I don't have many patients. I have only 18 patients in the past 10 years of optic nerve compressions and treated with, in past actually six years, optic nerve compression treated with tocilizumab. It doesn't seem that the optic nerve compression in thyroid eye disease blinds people very quickly. Some of our patients had optic nerve compression for years. When I'm saying for years, I mean it for years, not for months. You know, for 3 years, 2 years, and on verbal communication with Prof. Jeff Rose in London, he has patients that he has operated and vision regained after 15 years of optic nerve compression. So when I see now an optic nerve compression, I don't panic anymore. And I don't rush into surgery, and I don't recommend that actually. I would, IV steroids is good, dampens the inflammation a little bit, and then you can get the patient which we treated. So there are case reports now with optic nerve compression and teprotumumab. So my message here is that in our experience here in our department, and Dr. Fatma Habrouch, maybe she can comment, we don't rush now anymore into decompression surgery in these cases.
Thank you. Prof, do you have any
Okay, as you know, I can't use TEPRO in Europe, but certainly what I feel like confirming absolutely what was just said about Don, because we treat usually with steroids, the 2 courses of steroids. But what we have observed is true that some patients do respond very, very slowly and even late. So we do not rush the compression also, unless we have proof that these patients are not responding to any treatment in that case. Because some patients come to us after they've going through different treatment and even previous decompression. So in that case, they go to the surgeon right away. But if we manage the patient from the very beginning of the onset of dawn, we do observe that even here, the behavior is very heterogeneous. And we have seen patients decompress like after a year or a year and a half, gaining more vision anyways. So there is something that is not always the same with these patients. And it is true that this is a very indolent kind of syndrome. So you can really go in and do your job calmly and decide what to do without rushing. I agree.
All right. So other questions coming in as well. What is the average reduction of proptosis after TEPRO? This is from I presume from the optic and OpticX studies, which is a published study already. We can, I think it's Professor or Dr. Habib. Do you have any comment about the reduction in proptosis after TIPRO? I mean, it's obvious there is an obvious decrease that we see in the proptosis. What is your experience, Dr. Habib, the fact that you have tried it?
We have different results from right and left eye.
Okay, interesting.
Yeah, it's interesting actually. We looked at it. One of our residents looked into it, and we don't have a lot of numbers, but and you cannot rely on that really. But we see on average 2.8 approximately in the right, 3.5 in the left eye.
Excellent.
But we had of 6 millimeters, and we had of no response as well.
Okay, so
yeah,
from big spectrum.
Yeah.
Another question about the protocol that you are using to reduce the auditory side effects. What do you do, Dr. Habib, with the patients?
We don't do any protocols. You make sure people generally who have hearing loss, they are more prone to complications, okay? And it's not only hearing loss, actually. Our experience, again, our number is little, less than 20, but they have some pressure sensation, hyperacusis, and which all of them, they have improved. So that's one thing. So we didn't have any permanent hearing loss in the past 1.5 years, alhamdulillah. Now, avoid people who have already a hearing loss because of different causes, or caution them, okay? Caution them. That's one thing. The other thing is that you do the tests. We used tests before and at the end. Now we are going to start at the beginning, if possible, mid-cycle as well. And if you see anything, but don't panic again, okay? They wake up, they cannot hear anything. It's a gradual thing. And you can catch them. You warn them beforehand. It's very important. And when they know about it, they know what to expect. They can call you, they can call the secretaries. And yeah, this is what do you think, Prof?
Well, as I say, I mean, I cannot tell much about the experience. No, I was interested in what you said about the difference between the two eyes. And that goes back to what I was saying before, that certainly this is an organ-specific autoimmune disease. And I think that, that there are stories and studies done of why, for example, the disease in some patients is unilateral or more in one side than the other. And for example, the way the patient will sleep in bed, on which side the sleeping bed was studied to see if there was any relationship. But certainly the lymphatic drainage of the orbit, you ophthalmoplastic surgeon know better than I do, that is very confusing. There's not a clear drainage there. And so I think that whatever goes into the orbit stays there. And it is very much, I mean, we've shown that in patients, for example, we published a couple of cases of cytokine release syndrome after rituximab, okay, which is this massive release of cytokines after lysis of B cells. And these the cases we published occurred, all of them in patients with unilateral disease, because in unilateral disease, probably there is more B cells all in one orbit than in the other one. So the lysis occurs specifically in that. Whereas if you have very symmetric disease, this doesn't happen. So I really do think that whatever is in the orbit does the job. And I'm not surprised that you have some asymmetric response to treatment, because we observe that even with other drugs. There's different infiltration of B cells in one orbit versus the other one, or different drainage to some extent. So it's very interesting. I think that is something, because all of the clinical studies that have been done in any study, and especially the ones of TEPRO, they were taking care of relating always to the study eye. You would define the study eye, which was usually the eye more severely affected at screening, and then you would measure and you will rely on the effect of treatment always on that eye without considering what happened in the other eye. But I'm not surprised you may have different effects based on the different implication of the disease in the orbit. So I think it's very interesting, this observation.
Thank you, Prof. We have a couple of more questions to answer. There is a question about, how do you manage, the management of type 1 versus type 2 thyroid eye disease? I presume that's to do with the muscle fat component, Dr. Habib. What do you have any input in this regard? Do you manage them differently?
I don't.
Yeah, same, right? So if there's muscle, more muscle component than the fat, you would do the similar kind of.
Yes, because we don't have any guidelines saying that, okay, if the muscle is bigger than whatever millimeter, then use 6 milligrams of tocilizumab or whatever, or 20 or 3 grams of steroids. Okay, it's, as Prof said, it's the phenotype, it's the disease. Some they show themselves as muscles, and I don't know why that happens. Really, I don't know. Really, I have never thought about that. I never think in that direction.
Mm-hmm. Thank you, Dr. Habib. Another question for you, actually, about the selenium. Do you actually measure the selenium level before you start?
It's a supplement, and we give them for a couple of months, up to 3 months. Anybody can take it, and I think it improves the immune system of the body. That's it, But only for I give it for mild to a combination to the moderate, so mild to moderate only. Till I'm waiting for the results, for the patient to think about the treatment and so on. There is no harm. What do you think? What do you think, Prof?
Well, the story of selenium, the study was done by UGOGO. Various centers of UGOGO were involved in the studies, and the question was the big discussion we had, because by including various countries from Greece to Denmark, we know in Germany, at that time, some measures were made, and certainly there was the selenium deficiency in Greece, whereas there was not such a selenium deficiency in Germany. Data were pulled together because the study was on 300 patients altogether, 270 patients altogether, but it is possible that the effect was more marked in patients where there is selenium deficiency vis-a-vis the ones where there's not such a deficient situation. We don't know. So it might well be that if you're not selenium deficient, you do not have the same results. Nevertheless, this is reserved to mild disease, as you were saying. It's a short course of 6 months. I don't think that's going to give any harm because anyway, the relative selenium deficiency anyways. But this is a question. This is an open question. It's more difficult to measure selenium in patients, at least, I can tell you in Italy, than it is to give it to them and see how it works. To be honest.
Thank you very much. With this, I would like to thank Prof. Salvi.
I have one question from Prof, if you don't mind.
Yeah. Go ahead. Go ahead.
Two questions, actually, if there is time.
Well, we'll make time for you. We are over time, but if our participant...
Prof, recently, in the past 6 months or 1 year, I have changed the way how we speak to the patients about thyroid eye disease. It's just because thyroid eye disease is an immune system disease, and immune system is directly related to what you eat, what you breathe, what you smoke, and your lifestyle and everything. Have you looked or observed or do you want to study the effect, the severity of the disease in healthy and unhealthy people, the severity of the response to the treatment in healthy and unhealthy people, and the rate of recurrences in the healthy and unhealthy people?
There are no such studies, and we haven't done these studies. What we did, though, we were part of a European consortium, INDIGO, in which we studied the role of microbiota in this disease. And we published some data recently on the JCM last year. And what was interesting to see, and there's still some data we're working on, what is interesting to see is, for example, that in the experimental model of TED, whether, the model that was reproduced in Cardiff versus the model that was reproduced in Essen in Germany, and the two strains of mice were the same model, but were fed with different things, different formulas, they did develop two different phenotypes of disease. In one, there were antibodies. In the other one, there were no antibodies. In one, there was eye disease changes in the orbit. In the other one, there were no changes. And it's interesting because in the model of Essence, what we did was to treat patients with a probiotic, and with a we stimulated patients with fecal extract, okay? And then we administered the mice probiotic and vancomycin. And what happened is that by giving vancomycin, we would not produce TED. So that implies that possibly the microbiome has a role. And we also did find some specific microbiome in patients with eye disease compared to those without eye disease, patients who are hyperthyroid versus those who are not hyperthyroid. So I think that certainly the environment effects has a role. They were not studied like you are suggesting. I think it would be very interesting to look at that and see if people who are sick or not sick develop the same way. We know, for example, the smokers tend to have more severe disease. This has been reported. But we do have the idea, I mean, just the fact that the more severe cases come usually in male above 50 years of age, where the most prevalent disease usually is in younger women in general. So there is some effect, apart from sex, that probably impact that. But I think it's a very good suggestion for an observational trial. I think it would be very interesting to see that.
Thank you. Thank you.
We have another question, Dr. Habib? Or?
Actually, I think Prof answered that already. Does he agree that, I mean, he answered that about the length of the optic nerve compression already.
Thank you. I'd like to thank Professor Salvi and Dr. Habib for speaking today. Very valuable talks. I would like to thank our audience and participants as well. I'd like to thank Dr. Amgen for also helping us produce this educational series. I thank you all, and have a good evening. Thank you for joining us.
Thank you again for the invitation, and nice to see you.
Thank you.
Thank you. Thank you, everybody. Thank you, all the audience and Prof and Aya and everybody. Khalid, shukran, habibi.
Thank you.